Good morning, and thanks for your time today. Hopefully I can make it worthwhile. Thank you. Thank you very much. I'm Ghassan Salman, internal medicine from Austin. I work for Austin Diagnostic Clinic. I say I'm blessed to be the Chief Medical Officer. I do 50% of my time clinical and 50% of my time administration. I would like to tell you what we do at ADC. I'd like to talk with you about why quality. This is more at the national level. What are the driving force? Why we're spending time? Why we came here today, sitting, listening to us talking about the quality. So this is a few slides about the driver behind the quality. Just one slide about who we are. Then I'm going to introduce you to our quality improvement program. How did we do it at ADC? So why do we care about quality? This is a summary of a whole book, and this is a book, Crossing the Quality Chasm, published by Institute of Medicine, and I urge every person who is working on quality in their organization to get this book and read it, maybe read it twice. This is by no means a summary, but these are the things that stuck to my mind. Why we care about quality, why this care about quality, and a lot of regulation coming from the government to talk about quality. The main message is not the physician, it's the system. And let me tell you about the system. With time, over the past 20, 30 years, we're having more patients who have chronic medical problems. We have more patients who have multiple medical problems. This is one. Second, evidence-based medicine. Evidence-based medicine is expanding exponentially. There is no human mind that can read, understand, analyze, assimilate, retain, and get back this information and use it at the time of care when we're sitting with the patient. We need help, and the IT is the help. Third, a lack of adoption. If you think of healthcare, compare it with the banking system, for example. We are way behind other industry in adopting information system. And lastly, we work in silos. This is our mentality. This is the problem of the fee-for-service. What happened in the hospital does not always go back to the clinic. We have a lot of hands-off. You've heard this term a lot. We have a lot of duplication of tests. So these are the four main problems why we're in this problem. So how did this, what was the result of this one? This is the healthcare system. In the past, if you go back maybe 30 years, in the past our healthcare system was simple, not effective, but safe. You know, if you go back to I was in medical school in 1990. At that time, when patient with heart attack, we give them aspirin and we pray. You stop there. Now, healthcare is complex, effective, we get the job done, but it's not as safe. So we're gaining effectiveness at the expense of safety, and we're creating a complex system. Some national numbers. We as a nation spend 16% of our GDP on healthcare. Compared with other industrialized nations, they spend between 7 to 10% of their GDP on healthcare. Another view of the same picture, we spend per capita around $7,000 per capita compared with other industrialized nations that spend around $3,000 to $4,000 per capita, almost double. And there's no evidence that we are doing better. This is one of my favorite slides. This one here on the x-axis you have percent of patient population. Here you have percent of how much money spent. If you look at the second one, what it says is that 5% of the patient population are consuming 50% of the money. 10% of the patient population consuming 64% of the money. The healthy population, 50%, is spending 3% of the money. The message from this slide is that there's a lot of low-hanging fruits. We can cut cost and improvement of care on these patients. Our clinic, we are an outpatient multi-specialty clinic, independent from any hospital. We live in the same hospital with St. David's, but we are financially independent. We were born in 1962, so we're around 50 years old. 120 physicians, 600 employees, 21 different specialties. we see on average 1,550 patients per day. It can go up to 1,700 sometimes, it can go down to 1,400 on Fridays. We have electronic health records since 2000, and we are fee for service. And that's very important for anybody who are working on quality to understand that the payers make a big difference. We are currently still in fee for service, and we are a for-profit organization. Our quality improvement program, I'm going to go through four topics. How did we develop the quality improvement, and how did we drive it within our clinic? I'm going to try to do that within a few minutes. First, we have to explain to our physicians why we need quality. The driver behind the local drivers, and what was explained in the first 3 slides is the driver at the national level, the policy making. But why within your organization you need to focus on quality? So by this one, you engage their heart and their mind. You move them from the pre-contemplation to the contemplation stage. Then you develop the tools to help them move, which is developing and testing effective change. And then you give them feedback on their performance, and then you implement change. When it's become change is working, let's anchor it to the culture. And these are the things I'm going to go through. First, knowing why we need to change as an organization. This is our vision. Our vision is to deliver personalized best care as measured by disease outcomes. So our board of directors said, yes, this is what we believe in. Now, we're not going to say we're best. We're going to measure it, and we're going to tell you how good we are. And we did some studies, and these are examples from 2009. I thought a lot before I brought this one, but from a quality person, this is we breed on data. These are examples of past due services. These are per clinic. We have past due services on mammograms, colon cancers, patients due for annuals, which mean preventive services, spirometry evaluations, and diabetes and CAD care. We had gaps in these cares. So what we did is we developed a quality improvement committee. And the quality improvement committee, we attached a yearly budget. So the board has to approve that we're going to give you a certain amount of money to make a difference. We had members of that committee, both physicians and staff. We want to make sure that if we're going to make a change, that both aspects of the care, the people who are delivering the care, are involved in the change. We hired a quality improvement specialist. We have health coach and health coaches. We have disease registry through EMR. IT support. You cannot improve care without IT support. Quality improvement projects. We asked each section to come up with the quality improvement projects. And the 2 things we said, please use the PQRI, now we call it PQRS, measures, because that's what we're going to report to CMS. And what's nice about them is that these measures are already developed. They tell you what's in the denominator, what's in the numerator. They give you the ICD-9 code. They tell you what's the exclusion. So somebody did the job. Take advantage of this, and these are for free. So let them choose. What we did, we gave a list of measures to each section, and they choose which one they want to work on. And there should be an active participation, which means when the section identifies a deficiency, they have to decide what to do with it. It's not us. We as a quality improvement, we drive the process. The decision is per section. Examples of change. I'm not going to go through this. I present this one just to let you know that we study processes. And whenever you're talking about quality improvement, you have to understand the processes within your section. This is how the patient go through in the clinic, and which one is preventive, which one is chronic care, which one is acute care, and where are the faults can happen. And how you improve processes, you add certain expectation or jobs, actions to be done, and you specify who does it to improve the processes. Giving feedback mechanism. This is one of the feedback mechanism, this screening mammogram, and you see the definition is, this is PQRI number 112. This is percentage of women aged 40 to 69 who had mammogram screening within the past 24. And you see it is per section, and within each section we take the line per each section and we give them the graph, and below that graph there will be numbers per physician. But these numbers goes to each section individually. Another one is colon cancer screening. And again, we try on a quarterly, sometimes twice per year, to give these numbers back to each section and the individual physician's performance. CAD care for cardiology section, and you see in 2009, 2010, and the improvement. And all these data are also divided per physician. Diabetes care and internal medicine. This one to illustrate the effect of health coach, and when you have, it's somebody, it doesn't have to be health coach, somebody within your department need to be in charge of the disease registry. We as physicians do not have time to do this. We develop the guidelines of what they need to do. But somebody in your section, if you cannot afford a health coach, ask your nurse that they need to allocate half hour every day to open that registry, identify deficiencies or past due services, and you tell them what you need to do in each case. So after you primed your physicians, you develop tool to improvement, you test the improvement, you give back feedback to physician. So how do you anchor it? How do you make quality as part of your culture? This is how we did it. We have a yearly quality improvement award since 2007. When all our physicians get for the annual meeting, this one we elect our board members, we have time for quality to celebrate the quality improvement. And we give our awards per section, not per physician. So all the physicians in that section get the award. And we intentionally did that to stimulate the team thinking. Because when they developed the quality improvement project, they did it as a team. We have quality as part of physician evaluation process. We have a yearly physician evaluation that physicians go through, and quality is part of the expectation. Recently, over the past 2 years, we have been redistributing the money that we get from PQRS and PQRI as bonuses, but we change them based on performance. Which means when this money gets to this section, we divide them per section, and within the section, we redistribute the money based on who did well on these measures. Not on, because we get the money, as you know, we get the money based on 2% of your allowable charges for Medicare. So this money can come differently per each NPI. But we take this money, we lump them together, and we redistribute them according to performance. So the criteria is that the section, for them to get the money, they have to do two things. One of them, they have to show that they are proactively taking care of patient population, which means they have a project going on, and they have to be above the national average. So which means if a physician within the section was below the national average, that physician will not get bonuses. Strategy for the future, and this, I'm going to take liberty to put my own opinion here. The way I see it right now, at least in Austin, and what's going to happen in the near future. And this is insurance companies. Currently, we in Austin live in the fee-for-service atmosphere. All our contracts with insurance companies are fee-for-service. The fee-for-service drives physicians to focus on volume, see more, because every patient you see, you make more. When you have physicians focusing on volume, the structure of the clinic will be geared to facilitate physician-patient interaction. Rooming the patient, getting out, printing the paper, signing out, all of the interaction in the office is to help this one-on-one interaction between patient and physician. The future is going to be the insurance companies, CMS or private insurance, they're going to start giving us different kind of money. Fee-for-service will stay there for the short run, but there will be P4P, shared saving, bundling, global payment, PM, per month per member. That kind of payment is going to drive physicians to think two things, volume and quality. And when we say quality is cost and quality, which means how can you do this at a lower cost? And the idea is to reduce emergency room visits and hospitalization. When you have that, at that moment you start thinking, oh, okay, so what kind of structure do I need to get what that want? At that moment, it's not going to be one-on-one. It's going to be a team of providers taking care of patient population. If you think of your patients are not homogeneous. There are subpopulation within your patients. For example, you have the healthy patients who need preventive care once per year, get their immunization. You have the patients who are at risk, the obese, the low HDL, the family history of cancer, the smokers. These are the patients who you want to identify them, label their chart so that every time they come in, you try to modify the risk. You have the patient who have diabetes or hypertension or CAD. These are disease registry. Identify them, apply evidence-based medicine. And you have the complex cases. These are the patients who have multiple medical problems, who needs intervention from multiple aspects. Dietitian, a social worker, advanced nurse practitioner, RN, medication compliance. So in summary, we need to transform, irrespective of what's happening in Washington, we need to transform our healthcare delivery system from taking care of individual patients to a coordinated system that proactively takes care of patients' population. And if you're interested in the slide, just send me an email. I'd be happy to send you all the information that I have. Thank you.